the data, actually they were data I presented at ASCO, suggested, Michael, that you could have long-term survival with BRAF/MEK therapy.
Yep.
I mean,
Sure.
Right. And Jeff, one of your famous, to take one of your quotes, one of the urban legends in melanoma has always been, everyone responds with targeted therapy and then everyone progresses. And that's just, as we've known now, just not true, right?
No.
So there are a group of people who do incredibly well long-term
I
with
agree.
regorafenib and trametinib or vemurafenib and cobimetinib. And those are the patients with the good prognostic factors, as one would expect. So those are the patients it's really, really difficult to know
But
what
do you
to do.
stop the drugs?
Usually those patients stay on the drugs with the targeted therapies, and I think to your point, Dr. Rivera, I think that's an important one. A lot of patients, and I think a lot of the value for immune therapy is that you have that immediate response. You may or may not stop for toxicity or other reasons, and then the treatment-free interval after finishing treatment and remaining in a long-term partial response or complete response is very, very impressive off of all treatment with immune therapies, and I think that's a big advantage.
That's an element that I take into consideration, I must say.
and it's always BRAF/MEK. I mean, is there any place for a single BRAF inhibitor?
Well, if there's cardiac problems, sometimes, or ocular toxicity can be a reason to exclude a MEK inhibitor, but this is the exception. In general, you prefer the combination. You have a better outcome concerning efficacy, and you have a better tolerability. I would say, in general, the combinations are better tolerated than the monotherapy.
Yeah.
I will make one interesting observation, though. The only way we will ever settle the issue of immunotherapy first versus targeted therapy first is to do a randomized trial, and that started in the United States as a cooperative group trial. I just don't know that it's ever going to get done because there appears to be a preconceived notion that everyone should start with immunotherapy. So we are victims of our biases, and that will complicate that trial.
This study could be done in Europe, and
Yeah.
easily, I tell you.
Yes.
The 300 patients you need for this so-called SWIFT study,
Yes.
they would be recruited in 2 months.
Will the
I
ORTC do
told
such a
Mike
study?
Atkins, but yes, but there is a problem, administrative problem that we cannot.
No. I heard about the same issue from the United States. So there is, more gut feeling driving the decision. And once you sign in for a clinical trial, you must be convinced that it is ethically correct to randomize patients either to BRAF plus MEK or to IPI plus Nivo. If you're not convinced that this is the right schedule for your patient, I think you shouldn't contribute to the
Absolutely.
clinical trial.
Yeah.
That's the issue.
But
So-
the Italians are running a study where they're
Yes.
randomizing patients to
Yes.
BRAF/MEK and IPI/NIVO, and I hope that will give us some
Yeah.
information. And in
Combat
that
trial.
study, there's a third arm too, which is interesting, which is a run-in of the BRAF and MEK, and then a switch to immune therapy to really try to get to that other kind of notion that's been out there that maybe you start a BRAF mutant patient with targeted therapy for some duration of time and then switch to immune therapy.
I was
that'll be an
asking
interesting-
this in the plenary room today, and I have the observation with 2 personal friends, I need to say. It's 2 women in the early 50s who had both are suffering from metastatic melanoma stage 4. And one of them had a very high tumor load, and she was suffering, and we were believing she's dying immediately. She was in such a bad shape, ECOG 2 to 3, I need to say. Hospitalized, really bad. And both of them got BRAF plus MEK. And after 9 months, one had 90% shrinkage of the lesion, the other one 80%. And both were switched after 9 months, the other one after 12 months, without a progressive disease to a PD-1 alone. And fortunately, one is 1.9, 1 year, 9 months, the other one 2 years in almost complete response or complete response.
That is something that we do ad hoc, and it's, again, we have the gut feeling that's a good thing to do.
Yeah,
But
but it's
we-
not
we-
evidence-based medicine.
This is, I agree.
We have an EORTC trial that is going to be initiated very soon, where we evaluate combination of immunotherapy preceded or not by 3 months of targeted therapy. So
I like it.
really think it's good to do that in the frame of a clinical trial so that we
Yeah.
can have at least some conclusion.
So we can be data-driven.